Hello there. I'm Cindy Grines, the president of SCAI and the chief scientific officer for the Northside Hospital Cardiovascular Institute. Welcome to SCAI's session on Cath Labs Now. Today we're going to discuss navigating where does a Cath Lab fit in the cardiovascular service line and health network. We have a phenomenal group of individuals who are here tonight with us, and I wanted to thank my co-chair, Kirk Garratt, who obviously, is a past president of SCAI, and he's in charge of virtually everything at Christiana Care Health System. So he's going to be very educated and knowledgeable on many of these topics. We also have a group of many other high-powered individuals. Tony Farah, whom I've known for decades, is at Highmark Health. And Steve Manoukian, who's an FSCAI cardiologist who left practice, I think he said 12 years ago, and now he's deep in the woods at HCA Healthcare, in charge of many of the service lines there. And we have Vico Marziale, who's at the Ochsner and in charge of many of their service line functions. And then Jeff Popma. Jeff Popma, of course, you all know, is a past SCAI president, and also he's done lots of clinical research and publications, and has now joined forces as a chief medical officer for Medtronic. I want to thank all of the individuals for coming together tonight for this very important program, and particularly I want to acknowledge the commercial support from Medtronic, and this session is supported by an unrestricted educational grant. Thank you all for joining. The individuals have no relevant conflicts of interest. We're not going to really be discussing commercial interests during this presentations. And I wanted to let you know that there will be evaluation certificates and for CME and MOC, and you will receive an email from the SCAI Education with the evaluation link after the webinar. SCAI is accredited by the Council for Continuing Medical Education, and you can earn up to one MOC point and one contact hour for registered nurses as well. So with that, I think we will get started. And I wanted to introduce Kirk, who will lead off many of the topics, and we wanted to make this sort of a roundtable discussion and have people just chime in whenever they wanted to. Kirk?
Great, thanks, Cindy. It's really great to be a part of the group here today, and thanks everyone for making time. I think this is going to be a great conversation and a great platform for having a bit of a dive into some of the tense issues that surround the Cath Lab today, and its management, how we move it forward. And I'm going to start off by getting right into the briar patch, I think. I want to talk about a theme that touches on issues that are prominent today surrounding population health management and how we go about delivering equitable care. I'm wondering what this panel feels about our ability to meet those population health objectives and meet those targets for delivering care equitably by improving the way that we connect our services to the needs of the community. That's often held up as a theme in population health conversations. We need to right fit our care delivery plan for what the community really needs. What does it mean for invasive cardiology? What does it mean for cardiovascular practitioners? For example, we know in certain counties, in particularly the southern part of the nation, rates of PVD are extremely high, and yet services for PVD are not necessarily the match of the clinical demand. And in fact, as a consequence, we see higher rates of amputation in some counties. I'm wondering what this panel thinks is a reasonable approach for addressing that need. And I'll turn to Tony to kick it off, but anybody who's got an opinion, and I know everybody does, please just chime right in.
Thank you, Kurt. I mean, we can talk all day about this, but you know, some may wonder why we're even talking about this. And I would tell you, you know, healthcare costs have become unsustainable nationwide, and they've become unsustainable locally and regionally. And, you know, the more this has gone on, the more pressure physician practices and health systems have been kind of forced to do things that, you know, I would say most physicians would say, well, not so sure about that, but we keep doing it. And so At the same time, the way the government's dealing with this is by creating bundled payments, accountable care organizations, clinical integrated networks, and so forth. So they're leaving it up to us to basically answer this question, Kirk, that you brought up. So some of the things that some of us and others have done are along the lines of the following. So when you look at it at the end of the day, every time we improve health outcomes or health of a population, the total cost of care comes down. And what's been wrong with the system is the system doesn't allow us to do what's good for the population. Yet we're talking about how do we improve the population health. And it's because hospitals and doctors, we all get paid separately, and it's still fee for service. So when it's all said and done, and I love the example you gave about peripheral vascular disease and how to prevent amputations. Going back to what I said earlier, so when you improve outcomes, the total cost of care comes down. So in any situation where, if you're in a practice or a health system where you have a clinically integrated network or an accountable care organization, any of those things result in pretty significant savings. And so therefore, the more focus and therefore capabilities that are spent on, at least I'm going to say, standing up those capabilities, the better off in the long run everyone will be, first and foremost for the patients, but also for the healthcare providers. Because otherwise what's been happening, everyone's getting squeezed, and some of the cath labs and hospitals are being forced to do things they shouldn't really be doing. Because what happens is, the supply demand curve that you talked about is just mismatched and quality suffers. So my recommendation would be to really focus on the things that truly impact or improve patient outcomes, but to really do it in the context of not just the cath lab or, let's say, a practice, but in the context of either the health system or the community that may have at least the forum that allows physicians and the clinicians to really do this together, because I don't think this can be solved just individually. I know I talked very broadly here, and we can get into specifics, but I'll turn it over to the rest.
Steve, it looks like you got something to say. Add to it.
Sure. I think you started out with the word community, Kirk, and that's what we all do. We all care for the communities that we are in. And maybe we're a little fortunate. HCA has about 200 hospitals across the United States. So oftentimes in a given community, we have a fairly substantial presence, and therefore we assess the needs of the community and then try to provide those needs. So of 200 hospitals, we might have 100, 150 of those that have cath lab programs. We might have 100 or so that have open heart programs. In the case of structural, we have 50 of those hospitals that have structural programs. And our intent is to ensure, at least within our system, that we can fulfill the needs of the community. And Tony mentioned peripheral, again, you mentioned peripheral, that we have those needs certainly for urgent and emergent conditions, and then when necessary for those conditions that are a little bit more elective in nature. I think the cath lab has always been and always will be a significant, meaningful part of the cardiovascular service line. Arguably, just looking at the expertise on this panel, we know that that's waxed and waned over the last few decades. When we look at growth projections for the cardiovascular service line, usually the cath lab is not leading those projections. And at best, we see low single-digit growth in cardiovascular invasive procedures. We see changes in the demographic of the way procedures are performed, less invasive, different sites of care. But I think in terms of ensuring that emergency care exists in our own environments, emergency care exists for the needs of the community, for the needs of EMS, et cetera. The cath lab is vibrant, and perhaps it will take multiple systems in the same geography working together to ensure that their services don't unnecessarily compete with one another, but are synergistic with one another to perhaps get to where we want to be. So just some initial snapshots, Kirk.
You think that that can be done without stepping on some legal landmines?
You know, I think other countries do it better than we do. You know, I was struck, you know, years ago with other countries' abilities to create more unified call schedules, that certain hospitals were open on a given evening for STEMI call and the other hospitals shut down. It allowed for centralization of services. It allowed for more efficient care by EMS. It allowed for better utilization of resources. It allowed docs to be on or off call. I think there's definitely political and diplomatic landmines. I think legal ones are very close to that as well, and they're all interrelated. But I think societies like SCAI can be at the forefront of that, of changing the dialogue and advancing the dialogue to help get some of those things accomplished, Kirk.
Great. Vico, what are your thoughts about that? And I'm going to ask you also to opine on ways that we can have a better sense of the community need. You know, these reports about, you know, how much invasive therapy is rendered in a given county in a certain hospital type and so forth. Very useful information. I'm wondering if you have any other thoughts about how, at the community level, hospital systems might do a better job of gathering the necessary intelligence to know how to grow or contract their invasive program.
Right. I think when you talk about giving opportunity to everyone to have the services they need, I think usually the problem with the cath lab and the hospital specific is the incentive is not there. So we talked about, we come up with new technology, which is better quality care for the patient. And if you lower cost overall for the system, primarily the insurance companies, right? So you have this great technology out there that we'd like to offer to everyone in their community, but the incentive is not to the hospital financially, to be honest with you, where you might want to have these services at many facilities around. And they're good services. Like I said, the patient wins, the insurance company wins for sure. Overall healthcare expense, whether it's government or local, that all wins. But that incentive for that piece to provide these services more readily is kind of misaligned in a way. And that's where the struggle is, I think, on our end, at least from the hospital end, right? You want to be able to do those things in those localities, but you end up having to retract back because now you have to put it all in one location for better efficiencies, for better cost containment. And I think that's a little bit of the struggle, to be honest with you on that.
Yeah, Jeff, I'm wondering if you've got thoughts about that part of it, and I'm also curious about your thinking around how do I put this delicately? There's a sense that the corporate interests always just want to drive more utilization. Now, those of us on this call, and at least on the panel here, know better. But I'm wondering how you think industry interests can advocate for right fitting of services to the needs of community without the appearance of being self-serving.
Well, I mean, I think all you have to really do is look at the problem. And let me give you a couple of facts that we are very, very aware of within Medtronic. 30% lower diagnosis rates for Black and Brown communities of aortic stenosis. 30% lower treatment rates for either surgery or for transcatheter valve therapy. 20% increased mortality in those communities because they're not really denied enough therapies. And if you just look at those numbers, you have to say within the medical system and for whatever interest we have within our corporate environment, we're not doing the right job. And I think the U.S. News and World Report article that came out in mid-June or so showed these pockets and hotspots where there were tremendous undertreatments. So what we've done is we've taken 4 pilot communities, Birmingham, Alabama, Baton Rouge, Louisiana, San Antonio, Texas, Phoenix, Arizona, that are both for primarily Latinx and Hispanic communities or Black communities. And we've set up a pilot program with our structural cardiologists who are there. And the most notable one is, I think, well, they're all notable, but the most notable I'll mention is Antoine Keller, who's a Black cardiovascular surgeon in Baton Rouge, Louisiana. And what he's doing is saying, well, why is that disparity present? It's present because the communities aren't set up to be able to have the trust or the referrals in. So what Dr. Keller is doing is setting up a network, which is a community-based network of local organizers, of churches, of local leaders, to be able to raise awareness about structural heart disease to the community and get patients in for diagnosis and get patients in for treatment. So that's one of our 4 pilot centers. We're figuring out what the formula are to make it work, whether you use an empiric system for mining echocardiograms, based on race, or whether you think about how you set up local educational programs as the folks in San Antonio are doing. There's lots of things that we can do, and we're really only scratching the surface of where we stand with our disparities of care. But I think we're tremendously committed to do that, partnering with our physicians, getting to the community, identifying the formula to get patients in. I think that's really how we're going to be able to respond to community health needs.
That's awesome. It reminds me of the very successful blood pressure barbershop experiments in North Carolina and California. Same idea. You take the message where it's going to land well and make sure you have the right people delivering it.
Yeah, and I mean, at the end of the day, we don't care whether it's hypertension and people get meds or whether they get a new therapy that's going to be an advanced therapy for treating. It doesn't much matter. We've just got to recognize that we have a tremendous inequality of care in the United States, and everybody's really got to work as hard as they possibly can to try to fix it.
Super. That's terrific. I think that's a good start to the conversation. Cindy, do you want to introduce the second topic we wanted to be sure to dive deeply into?
Absolutely. So very, very interesting conversations. And I think that, Jeff, you brought up some amazing concepts with regard to disparities in care. In fact, SCAI is working very carefully on this. We have each of our 4 clinical councils at this moment. We're trying to compile data and put it into a publication, a white paper where we can discuss this and come up with actionable items. So we're right there with you. Anyway, the second topic is how can we align our cath lab operations with population health initiatives? And I think we did a great job of this when we rolled out primary angioplasty. There are all these sites, cath labs without surgical backup, and they were taught how to do primary angioplasty. And now they're doing a lot of angioplasty without surgical backup, even at the elective situation. But this alignment is still not there. I mean, there's a lot of rural areas that have no cath lab coverage whatsoever. And what was found when we rolled out this primary angioplasty is most of those centers ended up being in the cities, really, where they, rather than spreading into the rural areas, because there wasn't much in the way of cardiology, interventional cardiology in the rural settings. So I guess how can we correct that, and how can we align it, and how can we better adhere to guidelines, recommendations to improve the health overall, and specifically with regard to the cath lab? Now, Steve, you brought up declining volumes in the cath lab, and I have to say that I'm ordering a lot more CTAs than I ever have, but I still have a big problem. I just today had it rejected, and I spent 30 minutes on an appeal call, and it still was rejected. It's ridiculous, to be honest. So I don't know who wants to handle this. Steve, do you want to comment?
Sure, I'd be happy to. I think there's a lot of downward pressure on the cath lab and activities thereof, and those downward pressures are probably first and foremost clinical. That we're learning a lot more about what we should or shouldn't do in the cath lab, and we're also learning a lot more, perhaps, about newer non-invasive testing that may help us avoid diagnostic invasive testing, and at times maybe even more appropriately pursue interventional therapies. I think at the same time, there are some tailwinds, which are things like the complex PCI world that you all very much well know, the world of shock and supported PCI and protected PCI, and being able to do the operators that are on the phone and on this call, being able to do so much more than we could even 10 years ago, even 5 years ago. I think we need to ensure that the services that our communities need exist. And I think the trends that we will see, that we're seeing now, will be that we will have many more cath labs, many of which will not be in hospital settings, many of which will be in ASC settings, many of which will be in OP cath lab settings. And And I think one aspiration of those labs is to distribute services to rural communities where they were not previously available. That you might have an outpatient cath lab attached to a freestanding ED in a rural state that might allow time-sensitive illnesses to be treated quicker than they would have ordinarily been treated. At the same time, I kind of have a bias that the best oversight of cath labs are in hospital settings, where all of you are in the control room or looking over people's shoulders or saying, what did your data show in the NCDR registry? And I think if we get away from that and we don't find the ideal balance of a high quality cath lab and at the same time distribution of those services for population health, as you mentioned, Cindy, I think I worry a little bit. So I don't think we've found that yet. I think if there are incentives that are not well aligned with the provision of high quality healthcare, if there is a reduction in oversight of cath labs by lack of medical directorships, lack of SCAI members that keep a close eye, lack of well-trained staff, I get a little worried about creep. So I think the forecast for most folks that look at the cath lab, this is absent of structural heart disease, are flat or maybe modestly positive for the coronary world, perhaps a little bit more robust for the peripheral world, and certainly multi-digit increases on the mitral and aortic and structural side. But I think the cath labs will become dramatically more distributed in the next, tomorrow, but in the next 3 to 5 years without question.
Mm-hmm. So, Tony, would you like to weigh in on this topic, aligning cath lab operations with population health initiatives?
I was on mute. I should hold up the sign, you're on mute. Yeah, so just to add to what Steve said, not to repeat what Steve said, in the rural communities, what's happening is hospitals, which are primarily usually the #1 employer in those towns, they're under that pressure that Steve talked about. And so they're being forced to do things that, without necessarily having the skill set of, in this case, the cardiologist who can do those things. But as Jeff pointed out earlier, with this kind of huge percentage of patients who have peripheral vascular disease and all the inequities, it's what we're doing in our region is urging some of those rural hospitals that have cath labs to really, and we're supporting them because we have resources to support them, to build those capabilities to focus on things that they can do and they can do very well, such as treating peripheral vascular disease or endovascular disease in those cath labs, rather than kind of doing 2 cases per week or per month sometimes per operator, which as we know doesn't result in that. So that's one thing. Then the second thing I would say is we're also urging many of those health systems, but also cath labs in our region, which is a kind of a multi-state region, to really focus more on 2 things, really tracking clinical outcomes, which not everyone does, obviously, but also through their hospitals and health systems tracking costs. Because we've come to a day and age where if you don't tie outcomes with costs, you're always going to be reacting to, the fee-for-service environment and doing things that you don't necessarily want to do. And so tracking outcomes and costs and then sharing that with payers, what we've noticed is it's allowing many of those systems, of which cath labs are big revenue generators, to really structure the types of value-based contracts and arrangements that allow them to get an additional source of revenue. So I'm tying basically appropriate use criteria and tracking outcomes and costs with a new source of revenue, without which those places really have been kind of withering away in some of those rural counties.
I have a question. Do you think there's a place, so it's accessibility versus expertise, right? I think you want to have accessibility in all these areas, and you fear that you may lose some expertise. Do you think there's an avenue for essentially telehealth, but maybe, for lack of a better term, tele-instruction, where you could have an operator remotely assisting an operator in a rural community where you still have the expertise there with them? I mean, I think sometimes we need to think outside of the box to accomplish the goals here. And I don't know, you got. I'm looking at a lot of brilliant people right here in front of me on the screen, and to be able to share that without physically having to leave where you are, I think that would be pretty efficient. But just a thought.
I think
I'll
it's,
make
I
a
think
quick
it's, a, I
comment.
think it's a great thought. I mean, when I think about, I was doing STEMIs until 6 months ago, right? So part of our call was at the Beth Israel Deaconess, but part of our call 1 or 2 nights a week was in Plymouth. And if you know New England, it's kind of halfway between Boston and the Cape, a little bit closer to the Cape, and you can't get there from Boston within 30 minutes. So you sleep there, and there's nobody close. And I have to say, we've all taken STEMI call at little hospitals. You're the only one there. The nurses, are supportive as best they can be, but you're alone, and there's no fellows and there's no other people. And if you get a cardiogenic shock and the patient literally has no blood pressure, you might have an Impella there that you can put in, but no one's really seen it. And I think it's really an opportunity for the SCAI to think about training and education for the nursing cath lab staff. I think we probably have a lot of nurses who are on tonight, and that's incredibly important. As Vico says, that can be supplemented with some something, right? If it's not live with the case, it could be a training session from another group of nurses that come in and say, okay, just think about the fundamentals. Because there's no question that we're saving lives. I feel like there's no question we're saving lives when we're doing STEMIs without on-site surgery. Because those patients oftentimes wouldn't make it into a hospital without getting tremendously sick. So we actually do something. But because the volume isn't the same as a quaternary center, then we have to really focus, I think, more on education. And I think that's really an opportunity for the SCAI. It's an opportunity for us. It's an opportunity for a lot of people to really focus on training on the fundamentals of acute coronary syndrome care in the cath lab.
Yeah, it's a great comment, Jeff. And I just want to throw in a comment as well, that not only are we all more oriented toward the virtues of virtual health now than we were a year ago, for sure. But, some of this is sort of back to the future stuff. In the early 1990s, when I was at Mayo, I was part of a team that looked at how we in the mothership in Rochester, Minnesota, could support the conduct of angioplasty at 2 affiliate hospitals,
Yeah, I
each
remember that.
an hour away,
Yeah.
one to the east, one to the west,
That.
that didn't have cardiac surgical services. That was, prior to that being commonplace. And we set up back then a very elaborate and over the top in classic Mayo fashion support system with audio connection to the operator and cameras in the cath lab so we could see everything and slaving to hemodynamics. Now, back then, it was the kind of thing that only a place like Mayo can pull off, I suppose. But the technology that was required then was new. Now you can order it on eBay and have it 2-day delivery at no charge. The point being, we could imagine having the opportunity to support the kind of operator you just described at some kind of central place, perhaps run by an agency like SCAI, perhaps run by your health system, that could add an added layer of safety and expertise to delivery of healthcare remotely. What do others think about that whole idea?
I mean, certainly, I think
great ideas. And we do have the robotic PCI equipment in many cath labs, and I know that it has been tested remotely, so you can be separated geographically from the case. That's really there's a lot of kinks to work out in that, because sometimes, like, our internet can be a little slow. The make sure the the transmissions are adequate. But really, you could do that whole case by never touching the patient if you had an appropriate nurse practitioner or somebody there to load the catheters onto the equipment. That would be a possibility.
I mean, it seems like they're two very closely related concepts. One is, how good is the operator, and then how good is the environment around them, right? And so even the best operator, I think every one of us, when we're in the mothership, we feel a little bit different than when we're out there at Cape Cod, like Jeff was saying, right? And so you don't want to like outkick your coverage and do some interesting things, and then the patient has a deterioration after that. So I think the vision for Corindus, I guess if we can say the brand, is that not only will they be able to manage procedures at a distance, and I think that's what Siemens is hoping for, but at the same time, if there is the ability to load in unique algorithms of the way hotshot experienced operators can perform a case, then it might minimize risk, it might shorten the case time, it might improve the healthcare value. I think on the flip side, I think that the staff concept is a very important one. Much like the open heart nurse who hasn't taken care of an open heart in a month, he or she may look very similar to someone who says, well, I haven't scrubbed in on a STEMI in a month. And so what we've done with some success is in the markets where we have multiple facilities is not only cross-training amongst each other, but cross-training across hospitals, that if we have some low volume programs, can we have part of that call team be one individual from one of the higher volume programs, and then they become a bit of a super trainer. And I do think that it's been successful. It's been at least anecdotally successful in terms of perception by the staff that they're getting better training, perception by the operators that they at least know somebody, one person in the room. And I think it is something that could be adopted maybe in a way to ensure that there's some baseline standardization, maybe with a SCAI certification for cath lab staff. That could be a very worthwhile encounter for hospitals and low volume programs in particular. In fact, even resulting in a true full-on SCAI certification of cath labs, especially those that are not on a hospital campus or don't have the oversight that I think we're all accustomed to.
Yeah, if I can add one more comment to that. So we're talking about, thank you, Steve. You mentioned the low volume hospitals and operators. So, and we talked, Cindy, about the robotic, PCI. There's also outside of the technical aspect of this, you put yourself in that cath lab with not many people and maybe not a whole lot of experience in a remote area. A lot of those hospitals, before we get to the cath lab, have started installing, virtual ICU capabilities. Yeah. And a very large number of those hospitals now have that capability. So in addition to the robotic PCI, I think it would be important to even, since they already have this equipment, and by the way, it's not that expensive or hard to get, to bring that capability along with the robotic PCI to kind of instruct, as needed, right? Whether it's the operator or the nurses or the technologists on what to do, because in most instances, we're talking about either things that can go wrong or have gone wrong, and you'd rather have that kind of voice and the virtual voice there, in real time.
This has been an awesome conversation. I really like it. I'm gonna course correct us back a little bit toward the population health piece. I'm really trying to understand how we can do a better job of lining up cath lab work in a manner that's going to support each of our hospital organizations' desire to get ahead of the population health challenges. And everybody knows the dark clouds on the horizon that people have been squawking about for a long time are now overhead. I can feel it starting to rain. I don't know about you all, but my organization is really going all in on this. We're currently, I'm going to guess, somewhere in the 10% total hospital revenue and at-risk contracts currently, but we've stated as an objective within a little less than 18 months to be 50% or more in at-risk contracts. So that's kind of putting your money down in a very real way. And what that means to me for cath labs is we've got to make sure that we're serving our population the right way. It doesn't mean I have to reduce anything I do. It doesn't mean I have to change anything. I'm always looking for efficiencies and so on. But what it does mean is I need to make sure that I'm not over treating. And as Jeff pointed out, I also need to be sure I'm not under treating so that we aren't holding the bag for the consequences of either. And I'd like to hear from each of the panelists what your thoughts are about that topic and how some of you, if you're taking any action, what you might be doing. Maybe I'll start with you, Jeff.
Yeah, is the at-risk contracts that you're going into for care for first 30 days after a PCI? Is that what the at-risk is, or are you taking care of a population? Say we anticipate that 10% of the patients are getting to the Cath over the next 6 months.
It's all population based and it's agnostic to the disease state. So right now our at-risk contracts are with state employees and with Medicaid patients of certain types. But we're going to expand that and we'll capture all the Medicaid, all the state contracts, I believe the majority of the Medicare contracts and some private pay contracts as well.
Yeah, that's where guidelines and appropriate use criteria come in, right? Because you can't make a mistake by underutilizing. Say, oh, that patient that's got the unstable angina is probably going to settle down with some meds and be okay, and they'll call me next week. That's not the person you want to take a risk on if they're having rest pain. On the other hand, the atypical patient who comes in, you can't sort out what the chest pain is. They probably don't need a trip to the cath lab. So I do think that you probably are, and now the system is going to have to be much more guideline AUC based, because the judgment that we all have, where we'll probably be conservative and cath the patients just to make sure nothing's going on, you don't win in that situation, it wouldn't seem. You have to really be careful about exactly who you're doing it on, but as you pointed out, even more importantly, who you don't do the procedures on. Yeah, and efficiencies of care, and you're at risk for things. So, not multiple balloons. You're probably thinking about all those cath lab expenses too. Generic, driving the prices down of all our equipment, so the manufacturers are having a hard time. So it's really it's a hard issue to really deal with, I'm sure.
Do you think part of the issue is it bringing the services to the community? Well, there's rural communities and there's underserved urban communities also. So is it bringing the services to the community, or reaching out to the community, putting clinics within those communities, and maybe driving the procedural stuff back to the hospital where there's probably some cost efficiencies there, and to getting the people the care they need, but not necessarily putting expensive assets in every single location?
Yeah, I think that's what it is. I think you're right about that. I mean, I think that all of us, probably in our practices at various times have learned that you have an outreach place that you go to, and you go to the patients, and then you figure out who can be taken care of. Because driving into I still see patients at the BI, and patients who have to drive in and pay $30 for parking to see me for 30 minutes in the office. It's a long haul in for people, and so I do think that probably us going out there is sometimes more efficient. Kurt, are you doing outreach within your practice?
Well, kinda. We're not doing it the way we need to do it, Jeff. And I'm having conversations with my section leads now about that very thing, because as you've correctly identified, it all folds together here. To be successful in these new payment environments, we have to just simply trim the sails as much as we can. And I think we've squeezed efficiencies out of the lab to death, and we've done a great job of it. However, the situation calls for more. And part of it is, I think, and this is just my opinion, and I'm very eager to get your thoughts. I think the answer to the dilemma ahead is to not focus so strictly on kind of the operations side, but let's look at kind of upstream work here.
Yeah.
Here's a great example. We just came through COVID-19 2020, dreadful year, and of the many, many horrible things that happened, what did we see in acute coronary syndrome patients? And not just the STEMIs, but people who had ischemic disease that was accelerating. They would have come to attention earlier. They would have gotten appropriate care, and they didn't. Now, they didn't all die, although certainly they contributed to the excess mortality. But those that survive now, they're going to have greater degrees of ventricular impairment. They're going to need more services and so on. I worry that if we miss or if we ignore our opportunities to get ahead of that, we really are going to scuttle the whole plan, and we'll end up in deep trouble. What do you all think?
Yeah, so there's a lot to say here. The way, so I live in a payer provider organization, and Kirk, I think our two organizations are starting to work together. We can talk about that.
Hey, we're shoulder to shoulder.
Yes. But the way payers look at this is, that was the essence of your question, Kirk, is they look at the PMPM, per member per month. That's the total cost of a baseline total cost of a population, let's say in 2020, although that was an erratic year because of anomalous year because of COVID. But they take that and then they come to you and they say, okay, well, over the next, not just year, they go 2 or 3 years out, they say, okay, you know, we need you to be X% total population below that. And if you don't, and that's what we're going to pay you for, by the way. And if you go even below that, we're going to give you shared savings and so forth. Medicare does that through ACOs. 80% of ACOs don't make those shared savings, even though they put a lot of money in it. So what does this mean, right? So you back into it. And so data becomes very important. Asking for data from those payers is critical to understand what you're going to focus on, because like you said, you've squeezed the cath labs as much as you can. They're as efficient as they can, but then you hear from your hospital administration or whoever, well, no, you know, we're losing money. And so asking for the data allows you to really prioritize what you're going to focus on. And you're right, Kirk, it's more upstream care rather than, you know, once they get to the cath lab. So that's a big push that we're seeing actually nationally, but, you know, as you know, we're doing it in our own region. The other thing is when you come into the hospital and the cath lab itself, that's where the AUCs, Jeff, to your point, come in. I mean, you know, as you know, cardiologists were the first out, I think, with respect to AUCs years ago. And there's still a good bit of variation in care, despite what we all think, you know, we do every day. And I think, Jeff, you may have said that, right? You know, you may think, well, let's just cath this patient. Well, maybe not, because if you really look at those AUCs, you may not end up cathing this patient. Those are efficiencies within the hospital that you can achieve that will also, you know, add value. But the bottom line is the biggest bang for the buck is to get the data from those payers that allow you to focus on what exactly you need to do.
So if you're a member of SCAI and you're listening to this webinar or participating in it this evening, what should be the takeaway, Tony? I mean, or any of the panelists, is the takeaway chiefly that you need to double down on assuring that you're bringing the right patient into the cath lab, and you're not missing opportunities to either manage medically or manage with invasive therapies? Is that the headline, or is it deeper? And what can a rank and file member do to be a contributor in this?
Yeah, I mean, I'll take a stab at that. I mean, the cath lab is a relatively downstream part of the cardiovascular service line. So its role in population health is a hard, that's a complex question, Kirk. And so I think, you know, not to use cliches, but, you know, the incentives are not well aligned of every one of the stakeholders. And for that reason, the provision of high value healthcare is complex. I think this brings in, as Tony mentioned, data and transparency of data. It brings in clinical performance and clinical outcomes. It brings in the cost of care and the role of physicians and staff in high value choices with supply chain decision making and awareness of choices in supply chain decision making. It brings into play the appropriateness of patient selection. And since we all are at the mercy of the patient, number one, but really thereafter the payer, it will be in the payer's eyes as to whether or not we're providing high quality, high value care for those that we serve. So if you're going into the cath lab to scrub in at 7 in the morning, I think being aware of the appropriateness of the care you provide, being aware of the operational efficiency of the care that you provide, being aware of of the costs and options for other devices that may or may not contribute to superior outcomes will put your cath lab in a better position to be able to be thought of as a leader versus a laggard, because the margins in healthcare are challenging. And again, for the same reasons that Tony mentioned, wow, you did great. Just shave another 5% off that. And sometimes there isn't a 5% to shave. Your favorite nurse is gone. Your favorite NCDR coordinator is not working there anymore. Your quality person's gone. Hey, try not to use that ultrasound widget. Don't put in a closure device. Put in a closure device. I mean, these are just, hand-to-hand combat. And I think those labs, kind of final sentences, those labs that I believe have good medical and administrative leadership, I think if SCAI can help set the stage for what does a good cath lab medical director look like? What does a good cath lab administrative leader look like that can set the right environment and culture, sitting down, having transparency with those that are the stakeholders, I think will contribute to doing better. I'm not necessarily sure you'll do great, but I think you'll do better. And I bet any of the labs where you all have leadership roles have done better because of your expertise, but we just need to make sure everyone has that.
Yeah, I agree. I think what SCAI can do from an educational perspective, because let's face it, I mean, most cardiologists are too busy to really kind of read, an article, let alone educated on what we're talking about. So that's where I believe Steve is correct in suggesting that where our society can help is to provide the educational modules that allow them, and be, by the way, MOC modules that allow the membership to really understand two things. One is the two trends we just talked about. One is the efficiency within the system, in this case, the cath labs. So eliminate low value care, keep providing high value care so that you can keep reinvesting in it. And then two, understanding the bigger picture, because that's, Kirk, what you brought up is, it's not just like the cath lab is on its own, it's part of a health system, or the hospital is part of a health system and so forth. And so the more, to your point earlier, people understand what they can do upstream, and it may be the patients in their clinics, by the way, right? In order to, they get the data from the payer, they know what to focus on, they do the right things. That's what's going to bring the total cost of care down, and therefore allow those cath labs to continue to be reinvested in, so that you can do the structural heart disease and so forth.
I think from the financial perspective, the cath lab is kind of transactional. It doesn't measure the benefit of the clinical outcomes that reduce the cost of healthcare. And I think that's where the gap is, to be honest with you. We're very isolated in this silo that we're in, where we look at the cost per procedure, right, or efficiencies in the lab, and the big picture gets kind of left behind in that. So the expense of a cath lab is truly the expense of the cath lab. It has nothing to do with, it might have saved tens of thousands of dollars of care downstream. So that's where I think that's where it's missing a little bit.
So true. So Kirk, I think we should, don't have much time left, and there's a topic here that might be of interest. As new life-enhancing technologies are developed, how can we safely accelerate the approval, and how can societies like SCAI better implement training? So Jeff, maybe I'll pick on you.
Yeah, no. So, hey, that's my topic, right? So that's my topic. I can just start. So I'll try to be brief. It may be hard. Look, we owe a lot to the FDA right now because the FDA, at least on the structural side, has done several things. Breakthrough technology is one thing to enhance kind of reimbursement patterns and patterns. The early feasibility studies have been just phenomenal in terms of getting the experience that we need and into our hands for U.S. physicians. Innovative trial design, specifically within the mitral space right now, allowing to move forward a single-arm study in patients who are not surgical candidates and not CLIP candidates to allow TMVR approvals is another pathway. So I think that we've really been lucky, and certainly in the early days, say the early days that we were all starting out, all the good stuff was in Europe. If you wanted to find something really good, it was all in Europe. Now it's the opposite, because now our European colleagues say, you know, you guys get everything in the United States well before we get it. And we have to just keep that going. But we have to do it safely, and we have to do it with the right guardrails, and we have to do it responsibly. And that's why I've always been thrilled working with our US investigators on trials, because our investigators are incredibly smart, ethical, innovative, and they really can try new things in their hands and tell us what works and what doesn't. So I think we've made big progress in the last 10 years in terms of how we're going to get new technology to patients. We have to keep that going. Innovative trial designs, early access studies, breakthrough technologies, I think are going to be the mechanisms. And of course, the SCAI, we have to have some, you know, consensus from SCAI about how all these fit into the armamentarium, because you've got 4 big sponsor vendors right now that are actually doing things, all coming up with innovative technology. And then you have to coordinate all those that are coming to you to say what's right for the patients in general. So I think SCAI's right in the middle of the mix.
Right.
I'd probably add.
So Steve,
Sorry,
what
go
is
ahead.
your read on new technologies?
Yeah, I think I'd probably divide it into 2 categories. I think there's the pre-commercial space, and then there's the post-commercial space, post-approval space. I mean, one of SCAI's greatest resources is its intellectual capital. Your members are the smartest interventional cardiologists on the planet. Let's say it that way. How can we leverage that group to reduce the variation amongst our members themselves and those that aren't even members? So to me, I think on the research front, I think Jeff's points are great. How does SCAI ensure that all of us recognize the importance of high quality, expeditious research that reaches meaningful conclusions that lead to earlier adoption of meaningful therapies, right? So how do we advance that? I don't even know what that means. Maybe Medtronic, you know, signs a trial with SCAI, and SCAI finds 45 sites across the US, and that trial gets done twice as quick as it would have ordinarily. I don't know, but I think in importance of research front, I think SCAI could be a vehicle. Then number 2 is we have an enormous healthcare system, and we ourselves are screaming for help to help better train our staff, better train our nurses, better train our physicians. And I can only imagine if large healthcare systems have that challenge, and theoretically we have the resources we need, or some of them, that the individual or ma and pa hospital or community hospital or rural hospital just really doesn't have enough operators or nurses to be able to know what they don't know. And for that reason, I think that SCAI could be instrumental in training of new technologies, training of the Cath lab basics, all of the things that I think SCAI has actually done pretty well, but taking it up a notch. And sometimes maybe it is an industry partner or two that could help shepherd that along. So I'd say it's kind of a pre-approval, post-approval. Those would be the 2 big ones for me.
So with regard to training, we do a lot of education primarily at the physician level, and less so among nurses and Cath lab staff. So do you feel that there's a great need for that in the community?
Oh, I definitely say yes.
Systems where I work, the reason they're not well trained is they won't pay for their time to receive the training. You know, you're always so busy and the margins are so thin and they are cutting staff. So how do we allow these individuals to even go to these seminars?
Yeah, I mean, it's
Good.
Sorry, go ahead, Jeff. Go ahead, Jeff.
No, what I was going to say is that, you know, it depends upon where you are, because I've got to say every small offsite, STEMI, no cardiac surgery backup Cath lab that I've been to, the nurses and the staff are craving for knowledge, because they want to know how to work if that emergency comes in. Maybe less so in the tertiary quaternary centers, although I have to say I'm especially loyal to my staff at the BI because they always wanted to learn more. But in general, I do think that there's opportunities to do this because Vico mentioned, telehealth. Just think about how we've been doing Zoom calls in the last year. I mean, we didn't do Zoom calls like this before, but you'll have some Zoom calls that you do for educational purposes. There'll be 100 people on. So it's so much easier now to put together good educational programs for cath lab staff. Something like case-based, something like, here's your RCA STEMI. Let's see what happens when the vessel reperfuses and how do you handle the bradycardia and the hypotension that happens. I think there's opportunities for do case-based teaching to our cath lab staff, particularly those that are in rural communities, because that's the stuff they need to be seen and be aware of.
I think that could be something excellent that SCAI could do, to be honest with you. Because again, with the telehealth, whether it's virtual reality we have so much more access to just technology now that really makes this much easier to do. Saying we can't send somebody to California right now because they don't have the time to send them, that's a fact. If we're relying on that, it's not going to happen, But if we can figure out a way to bring the valuable education to them, that would be a pretty big deal.
Yeah, I think it's a big thing. I mean, we'd be interested in doing that as well. I mean, that with SCAI, it's a good program with SCAI about how to train the remote cath lab staff that really wants to know what to do when that 1 in 100 time comes in, and they really want to understand how to take care of the patient.
Okay, we've only got about 2.5 minutes left, but I'm dying to get an opinion from this erudite panel. Over the past year, we've had the COVID-19 vaccine experience, which is there's plenty of room for criticism of many parts of it, but I think that we have to all admit that one of the resounding successes was the successful partnering of government agencies with private manufacturers to do a public-private arrangement that was really the linchpin to doing this very accelerated development process and bringing something to market so quickly. I'm just wondering if any of you feel that there are any lessons in there that we might carry away for the development, evaluation, and approval of new coronary or cardiovascular devices. Do you think there's room for that at all?
Well, I'll go first to give a 30-second, answer to it, and that or less is that this was a catastrophic emergency for us of proportions that we'd never seen in the United States. We all know that. That's an understatement. We've all been in our homes for a year, not going outside. So all of the expedited FDA processes, the expedited partnerships, the funding, I mean, it was all deserved. And we're going to make big mortality differences by being able to get everybody vaccinated. I think that's a kind of a once in a lifetime experience. When it's not that dramatic, absolutely. We need to work on some more public-private partnerships to move things through. But I don't know that we're going to come up with an mRNA vaccine in a year or equivalent. That was pretty incredible.
Pretty magical. Well, Cindy, can I kick it over to you for closing comments?
Sure. Well, I wanted to thank you, Kirk, for co-chairing this and asking so many important and insightful questions. And I wanted to thank all of the panelists because, it's a diverse group here from all different aspects of industry and, big hospital systems. And so it's been very, very enlightening. I've certainly learned quite a bit. And I think that SCAI, we can pick up some ideas based on what everyone perceives the needs with regard to education of our nursing and cath lab staff and you raised a lot of great questions. So thank you so much.
Great, thanks, Cindy. Thanks, Kirk.
Great.
Thank you.
Thank you.
Thanks,
both.
everybody.
Thanks,
Have
everyone.
a great night.
Bye.
Thanks all.
All right. I enjoyed it. Thanks, guys.